No, what do I do? What do I do about it?
Yeah.
I should ask some of the members of us if we can record this, so because can't make it tonight because they're doing their taxes.
Of
That'd
course.
be tomorrow night, Hamish. Yeah.
Yeah. Absolutely. Yeah, I'm fine with it. So
Thank you.
shall I just crack on now?
Yeah, go ahead. Yeah.
So if
Thank you
can keep an eye on and admit anyone else. So what I'm going to do is I'm going to introduce myself and my kind of reason, my background and my reason. Then I'm going to really briefly introduce, or let them introduce themselves, three of my, I want to say colleagues. We work together, but we don't. We're all separate, but we all liaise and support each other. Because Myo is a very small world. We're very few and far between. So it's really important to me to have them on to support me and for you guys to be able to meet them as well, because they're all in different corners of the UK. And then I've got a presentation for you. It shouldn't take too long. Just going over what exactly is Myo. I'm going to show you some exercises as well. It's a little bit of an interactive bit, and then just time for questions at the end. So, as I say, my name's Emily Kirkcaldy. So obviously, Alison, you'll know how to say that and spell that, but most people don't. I accept anything really, just Emily K. I have my credentials on the screen, as Hamish asked me when he first came on. He went, what's a SALT, what's an OMT, and what's a BBM? So SALT stands for Speech and Language Therapist. And that's my primary profession. That's where I've been for almost 20 years now. Then OMT stands for Orofacial Myofunctional Therapist. And my three friends and colleagues on here tonight are also fall into that category. And BBM is Buteyko Breathing Mentor. Okay, so as I say, I've been speech and language therapist for almost 20 years, and I've worked in various different clinical settings with adults, with stroke patients, voice patients, but predominantly in pediatrics. And for a long time, there'd be certain patients that I would think, you know, this patient has made progress, but not quite as much as I'd like. And there's just something missing, and I don't know what it is. And it was 4 years ago now that my eldest child was, she was 8.5, nearly 9, and starting to develop her adult teeth. The adult teeth were coming in, and they were crossed, the central incisors were crossed. And she's always been quite a tired girl, I would say, and things. So I started to look into it, and I asked a dental colleague, dental friend of mine, who said, Emily, it's not anything to do with her teeth, it's the size of her jaws. And the size of her jaws, her jaws are small because she's been mouth breathing and her tongue isn't sitting in the roof of her mouth. And that to me sounded like absolute nonsense. This is the same dentist who had advised me a few years ago, previous to that, when we were all on a hangover, that if you taped your mouth at night, that would lessen your hangover symptoms. So at the same time, I'm thinking, okay, this is all quite interesting. So I started to research it some more. And once I was into it, I couldn't get out of it. I was absolutely mind blown and fully invested. So I went and did some training with AOMT in America and became an OMT. And that since followed numerous other trainings that led me to then work with Myofunctional Therapy UK with Yuli Tamayo-Myerson, who you may have heard of, and to meet the acquaintance of these lovely ladies. So could I just ask you each individually to introduce, oh, I forgot to, I missed a bit. I'm based in Manchester. That's how I became acquainted with Jo. I was working online from Manchester, but via London. And since November, I started my own myofunctional practice in the Northwest, which is the first and only at the moment. So I'm just going to then hand over first to Jill to say a quick hello, then Jenny, then Caroline, if that's okay.
Hi, I'm Jill. I have a dental background, so I trained as a dental hygiene therapist. And yeah, similar kind of journey as Emily to kind of get here. Issues with my breathing, my children's teeth, constantly seeing patients with perio that we couldn't sort out, orthodontic relapse all the time, TMJ issues that was never solved, grinding teeth, have a mouth guard, and thought there had to be a different way. So that's kind of how I got here, and I'm based down in Stroud. I'm also up in Leeds, and a few other places as well.
Jen?
Sorry about that. I'm Jenny. Lovely to meet you all. I train with Jill at King's. We did dental hygiene and therapy nearly 15 years ago. So I've been a hygienist since then, therapist, and trained with the AOMT as a myofunctional therapist nearly 4 years ago now. And I've done similar training since then as Emily with Buteyko breathing, Myomunchie, Myobrace, and I've also trained in lactation support. So I mostly treat young children, but all ages as well. So I see a lot of babies for orofacial assessment, and providing guidance and support to parents from very early on to help improve function from birth, really. So yeah, I'm based in Southwest London. Yeah, majority of the work I do is my own now, but I do still work in dentistry as well.
Thank you. Caroline?
Hi guys, thanks for the invite, Emily. I'm Caroline, I'm based in the northeast of England. I'm also a dental hygiene therapist. My journey a bit different. I got a bit frustrated with the system, people not getting any better, and taking teeth out of kids just used to break my heart. And I kind of set off on a quest to find out more information for parents more than anything. And so I actually studied nutritional therapy. So I am a nutritional therapist as well. On that journey, started from following a lot of functional dentists, particularly Dr. Stephen Lynn. Went to see him when he created his book in London, when he was doing his book launch in London. And he kind of opened my eyes to airway health. He said, you know, whatever nutrient we're deficient in, oxygen is number one. So that kind of blew everything out of the water when it came to nutrition. Went off to study myofunctional therapy, Buteyko. Finished my nutritional course. I actually predominantly work in my dental practice. I'm really fascinated with personalized perio. Having nutrition knowledge it just gives me so much information when I look in a mouth now. So I'm busy creating kind of personalized perio protocols and really making people aware of the airway impact and the disordered breathing impact that it has on oxygenation, sleep, and therefore healing processes. I also love pediatrics and really trying to educate clinicians, but also parents and kids on the functionality of the mouth. So for me, kind of the oral impact of not being able to chew and breathe at the same time. So really that oral phase of digestion, I'm really interested in that. I do have a private clinic that I see my myo patients. I particularly like the hands-on side of things. So the TMD patients, I'm a massage therapist. I've done a bit of TMD work. So I like getting my hands on people. So yeah, that's me. And thanks for the invite.
Okay, I'm going to share my screen now. So thanks, ladies, for introducing yourselves as well. And, oh, hang on, has that worked? Let me stop and go back. I did rehearse this. Let me try again. There's nothing worse than this. I rehearsed it so it definitely wouldn't happen. Okay, try this. You can see that. Good. Can you see that? Somebody give me a thumbs up.
Yes.
Or good. Thank you. Good. Okay. Let's present. Okay, so I'm going to give you a really brief history and the theory of myofunctional therapy. Then I'm going to tell you about what it is and who can do it and who's it for. Then, and then how it works. And then finally, some of the outcomes that we'd expect and the kind of joint working that we like to do that we know help to benefit our patients. So I'll make this one really brief because I'm sure you are all too aware of it. The history is that the jaws of our ancestors, when we dig up those bones and we look at Neolithic man, their 32 teeth fitted their face perfectly, and I had more forward facial growth, evidencing more nasal breathing, better chewing patterns. And then around when history books started and we have documentation of teeth and things, there was more thinking along muscle function being really important in dental development. Come along the Industrial Revolution, and obviously changes have happened in diet and children not being breastfed for as long, medical advances, perhaps babies that were tongue-tied would not have survived, and then they had done. And a lot of other things such as allergens and pollutants that have affected the way that we use our mouths and the way that we breathe. Then coming up to in the 1900s, of course, there's the work of Edward Angle that I don't need to go over for you guys. But then there's the work of Alfred Rogers, who was considered the kind of forefather of myofunctional sciences and myofunctional orthodontics, who was the first one to document and start to look at the fact that when muscles were dysfunctional, teeth became that way and airways became that way. And that was started in the 1940s and 50s and has kind of grown in popularity since then. And up to here on the blue, where we are now, the blue and the black, is that in the last 10 years, there's been a massive increase in awareness and a massive increase in evidence base, which is something that we've always been lacking. And there are new documents coming out all of the time. We've got so many amazing academics from around the world, many of them in Brazil, and we've got Dr. Zaghi in America, and some really dedicated people who are all out there advocating and getting that research out there for us. And then multidisciplinary involvement. Because of that raised awareness, we've got more dental and medical and healthcare professionals who are all starting to see the link and starting to sing from the same hymn sheet, which is great. So I pinched this slide from, and I've added it on there, the Breathe Institute, who is which is run by Dr. Zaghi in California, and amongst us myos, it's kind of regarded as the gold standard for airway health and all things myo and airway. So he coined the cycle of dysfunction, which I'm going to start here at restricted tongue mobility. So that could be a tongue tie, but it might not be. So a tongue tie then causing low resting tongue posture, so tongue not sitting lightly suctioned into the palate and resting down in the mandible. When the tongue is low, air can go through the mouth and we start that pattern of oral breathing. That in turn, when the tongue isn't sitting lightly suctioned up into the palate, the palate isn't able to grow, the soft tissues and the bones aren't able to respond to the pressure from that tongue to grow, which then leads to limited tongue space, which then leads to more dysfunction, more oral myofunctional compensations, so overusing of the jaw, overusing of the lips, different body postures, and all sorts of different things, which then again can feed back into tongue mobility. And this one's a little bit tongue heavy, and I do think that that cycle of dysfunction can be doesn't have to start with a restricted tongue. The low resting tongue posture there and the mouth breathing can be caused by an airway difficulty, which can come from something nutritional, something environmental. the kind of things that Caroline mentioned there. So our job as orofacial myofunctional therapists is not only to address those things, but the first and foremost thing is to assess those things. We assess them and we reassess them. We're always reevaluating those things in our patients along the way. So there was multiple images I could choose here about the kind of impacts of orofacial myofunctional disorders. So that cycle of dysfunction. And I like this one because it's twins and it's quite stark. And so you can see here, the girl on the left has been the nose breather and the girl on the right has been the mouth breather. There's a massive difference in their facial third distribution, probably their facial symmetry, though we're seeing them from just that side angle. We've got that mentalis activity here on the girl on the right, just to keep those lips closed, and how much harder she's having to work to do that. We can't see what their head posture is like, whether they're holding her head forward, but I imagine that would be the case because that is what we ordinarily see. Her eyes are more sunken. She looks like a less healthy and less well-adjusted, less happy child than her sister. And also the breathing playing the direction of the nostrils and the size of the nose and the way that we can see the airflow is going is also different. So hopefully, I mean, I'm sure there are also many more things that you guys in your profession would spot. And that's before we even look in the mouth. And that's also before we talk about symptoms. This is just what we can see. So what is myo? What is myofunctional, orofacial myofunctional therapy? I'm just going to call it myo from now on because it's a mouthful. So it's neuromuscular repatterning of the muscles of the orofacial complex, treating dysfunctional patterns and bringing balance to the stomatognathia system. So when that cycle of dysfunction occurs, we need to assess it. We need to unpick exactly what's happening. And then we need to work through a fairly systematic process to undo those things to help that patient. And that includes working on the tongue, the lips, the jaw, the pharynx, posture, breathing, nasal breathing, and all of those things, which you'll find out some more as we go along. So we work to treat not solely, and again, we'll talk more about teamwork, but myofunctional therapy itself treats the following. And there is at least some evidence for all of these things now, and it's all growing day on day. So sleep disordered breathing, apnea, bruxism, snoring and unrestful sleep, TMJD, don't need to go into any more details for that for you guys. Speech, chewing and swallowing difficulties. So quite a lot of people with orofacial myofunctional disorders will have difficulties with some form of articulation, voice or fluency. There is currently no research in the world that links disfluency or stammering with tongue tie, but amongst the speech therapy community of people who are trained in both, we are under no doubt about it. And every dysfluent patient that I've seen since I've known about this has breathing disorder and some form of OMDs. So it might be tongue thrusting, it might be inadequate chewing, dysfunctional swallowing pattern. Oh, I've just spotted a spelling mistake. And unbalanced or inadequate chewing. We're also treating craniofacial development in kids. Well, I say treating, we're guiding craniofacial development in kids to prevent further dysfunction, supporting the growth of the jaws and the cranium. Because as I said before, and as you guys know, the soft tissues in the bones respond to that pressure from that light, constant pressure of the tongue. And there are many other benefits as well. So we see progress in posture, facial aesthetics, which is not something we ever advertise because that's an entirely different thing, but it's just an added bonus. We see progress with sensory regulation and alertness and concentration, digestion, oral hygiene, and improved respiratory health. And because of those things, the patients that we see often report a general feeling of better wellness. Whoops. So how it works. So there are 4 main goals of myofunctional therapy, which we cover over the time. We don't tackle them all at once. So the first one is we want our patients to have habitual nasal breathing day and night. The time that we do breathe through our mouths, and I'm doing it now, is in between sentences when we're talking and when we're singing. And some other times as well when we're doing certain oral functions, but on the whole, we want our patients at rest to be nasal breathing. We want natural lip competence. We want the correct tongue rest posture. This is a really important one for us, and the correct swallowing patterns. So I'm sure you've probably seen this infographic before, and again, I picked it because I think it's a really great one about the wrong and the right tongue posture. So what we are looking for is the whole tongue to be resting in the whole palate, not just the front sitting at the incisive papilla. We want with the front tip to be sitting at the incisive papilla, not sitting low or forwards, but we want the rest of the tongue, including the posterior 2/3, to be sitting all up there in contact with the soft palate, because that scaffolds the airway and keeps all of those tongue muscles and those pharyngeal and velar muscles and those muscles all in correct balance, keeps them toned. And lastly, and really importantly, I'm going to give you the 3-legged stool analogy. So obviously the jaw joints are part of how we stabilize our jaw, but the tongue is kind of like the 3rd leg. So if you imagine a stool with 3 legs, then if your tongue isn't sitting up there into the palate, then you haven't got that last piece of stability. So those jaw joints are working extra hard. And in fact, we shouldn't have to be working to keep our jaws closed or our lips closed. It's the lingual palatal suction that does the job for us if it's doing it correctly. Correct swallowing patterns as well is to do with very much like with this this diagram, keeping the tongue tip at the incisive papilla and then the rest of the tongue making this peristaltic wave to properly form and massage the palate and to take away any compensations from the facial muscles that cause issues over time. So what does it involve? Whoops. The first thing it involves is commitment, and that's a big one because it typically spans 18 to 23 sessions. Practitioners work differently, and I personally don't always prescribe the 18 to 23 sessions because people can find that quite overfacing financially and logistically. But as a gold standard package, it takes that long to fully repattern that neuromuscular system. So we need to make sure that our patients are fully invested. It takes tools. So we always use tools along the way. Everyone is very slightly different. Here's a bag of tools and it's an example that I will give out to patients. You'll see them more in a minute. And we're doing exercises with those tools, not always using tools, some are without. And we're going to be asking our patient, we're going to be demonstrating them to the patients, feeding back to the patients and making sure they get those just right so that we're working on the exact muscle groups that we need to be. And we're going to be asking those patients to do those exercises 3 times a day, every day. So there goes back to the commitment. It's quite a big commitment. We say the more you put into it, the more you get out of it. So we do have patients that slack off a bit and do their exercises maybe only once a day. We can't realistically move them on to the next phase of therapy or the next set of exercises because the brain hasn't gone through the right pathways enough times for that neuroplasticity to work, that brain retraining that we're doing. And strengthening as well. So some myos will say twice a day, most will say 3 times a day. So there's that strengthening and repatterning element with the exercises, but there's also this self-awareness, and that's definitely not to be underestimated, because that's a big part of neuroplasticity and retraining ourselves, is to be self-aware, but they need to understand what they're being aware of. So there's a lot of education involved in it at each level, and we do even use little aspects of CBT. We use little things like EFT tapping to help patients to realize where their tongue should be, or whatever particular barrier or block they're having. And I think that's why we do it well. So I hadn't mentioned yet that myofunctional therapists in the UK are either speech and language therapists, dentists, or dental hygienists and therapists. And that's because of their in-depth knowledge of the stomatognathing system. We've obviously gone on and done quite a lot of extra training to reach that accreditation. But going back to that self-awareness thing, is I think that we are so well placed to do that because of our therapy background and our ability to really be analytical and to relate to the patients. And then finally, team working is we just cannot really realistically do this job on our own. Somebody can go through a course of myo, but they're always going to get extra benefit if they're working with other professionals as well. And of course, they're part of the team themselves, the patient. So here's the fun bit, the example exercises. So there are so many different, there are probably 50, 100 different exercises that we do in different combinations and at different times in therapy, because we're working through certain different stages. So I'm going to give you I'm going to stop sharing now, and I'm going to pin myself. I'm going to try to pin myself to the top of the screen so that it'll just see me. That worked? You can just see me now? Yeah, somebody give me a thumbs up. Can you see me?
I
Yeah,
can see you,
right.
but I can see everybody else too. I don't know.
Okay. I'm supposed to be like biggest. I don't know how.
I can speaker. Now I've got
We
you.
could all put you on speaker.
I'll put you on speaker.
I've got you on speaker. So
the only fly in the ointment there is I was going to ask Jenny, Caroline, or Jill to talk through what I'm doing to speed.
well, maybe that'll work though. Maybe that will work. Yeah, okay. I don't know.
Right. So we're going to do lip pops. Okay. And I'm going to ask Caroline just to chime in this time. If I don't give you all a job, I think you might just all blurt out at once. So
can you hear Emily's pop? She's rubbing lips to milk.
Can you? It's the audio settings on Zoom. Hang on. If I move further away, it works.
Yeah, no. Excellent. I can't hear the pop though.
Okay. Do you want to talk it through, Caroline, for me?
Yeah, lovely. So it's a bit of like resistance training. So Emily's popped the button behind both lips, and she's allowing the lip muscles, the ocularis oris, to function here. And it's like a resistance training for the lips, but it's also kind of pulling forward. So it's kind of a face forward exercise, and then she's using the side of those muscles as well. So quite often you will find patients who might have a stronger lip on one side than the other. So we'll prescribe exercises more on one side to see if we can even out the lips. And it's all to encourage the lip seal. So we're encouraging those lip muscles so that they keep that seal.
Yeah, Brill, thank you.
Little kiddies love that one.
Yeah, we sometimes call it the tug of war. They like that. And then I'm going to do tongue clicks now. So Jill, do you want to do?
Okay, so quite often when people have got low tongue tone, they find it really difficult to get that lingual palatal suction. And quite often people, especially when people hear about sort of getting tongue to the palate and things like mewing, what they try to do is try to get that elevation with the tongue by compensating with lots of different muscles, and also using a lot of work in the jaw from a TMJ point of view. That's why I see a lot of work with people going on in the jaw. So what we're trying to do is get that strength, and we quite often use bite blocks and things like this to get the strength in the tongue with out the compensations, so that you can start to get that natural rest position of the tongue and on the roof of the mouth. Because if that posterior 2/3 of the tongue isn't strong enough, you're never going to get a relaxed resting position. And then you can see the frenulum there that's blanching as well. If people have got a restricted tongue tie, what we can start to do is to start to kind of get that frenulum blanching and separating slightly from the back of the tongue as well, if they've got, you know, issues with the tongue tie. And also engaging the floor of the mouth. Very good demonstration.
Thank you.
And Emily, sorry, can I just ask, in the middle of that, did you also demonstrate how it would look if somebody was overcompensating, moving their jaw?
When I was doing this?
Yeah.
I wasn't meant to, but perhaps I did.
No, I know. I'm
just trying to show you when Jill was talking about how the jaw is involved in that. I'm just trying to show you from that angle, so you could see the angle of the mandible. And then I did a little TikTok as well, which is good, with a bit of a lip synchronization as well, which is a good one.
The click clocks can really help, because what happens is sometimes if you do the one exercise too long, you can start to get lots of tension. So it's quite nice doing the mixing the both. And from a sort of talking about a TMJ dysfunction point of view, we'll probably talk about swallow later, but the reverse swallow function is really, really important as well. I haven't seen any TMJ dysfunction patients that don't have problems with their swallow. It's really interlinked, because you're getting compression of that TMJ joint so often. So that's what we see, and we try to do with the exercises, is get some decompression of the joint as well.
Awesome, thank you. I'm going to do the spaghetti string, the weighted string, Jenny.
So for weighted string, sometimes we prescribe just the string to begin with, without the weight. Emily's obviously had loads of practice, so she's able to bring that up beautifully. So we're working on lip seal. We want the lips to be entirely around the string when the patient's bringing that up. And we're also working on tongue position. So it's the tongue and the lips that are bringing the string up. So the tongue is making this kind of action on the palate, going from the incisive papilla. And when we have the lip seal, we're preventing the tongue coming through the teeth, potentially causing any kind of bite issues. So it's a really good exercise, because we're working on more than one thing at once, which quite a few of the exercises, that's the case.
I know it's gross.
Oh, now you've got two weights.
I've got two weights. I just demonstrate that.
Yeah.
Because of the tongue retraction, my what happens is I end up with a little ravel. So you think,
Yeah.
oh, where does it go? And we want it not to be down under there. And most people worry, I think, that they're going to gag on it. But when the pattern is correct, we end up with a nice, neat little snaky thing, don't we?
Yeah, exactly. So it's all about control of the muscles as well. Sometimes for really little children, we would ask the parents to cook a big bowl of spaghetti, and we might use al dente spaghetti if there's texture sensitivities. But yeah, we've got lots of ways around certain exercises to make them suitable for the really little ones as well. So from about, I would say, 2 years, we can start to do these kind of exercises.
Yeah. I'm going to do some cheek puffs, Caroline, and then we can maybe talk about some blowing exercises as well, so we could get a couple of those bits out.
Yeah, so Emily's just putting blowing air into each areas, so both cheeks and then upper lip and lower lip. And quite often you find that some people can't actually blow in one area, so we're stretching that the fascia in the cheeks as we're blowing, and we want the air to be in each compartment as well. Again, not overcompensating, so you'll often find that when patients do that, they will overcompensate, but we're trying to have it as even as possible.
Ball and pipe out now, Caroline.
Yeah. So this is a brilliant game for strengthening the diaphragm and also circular breathing. So you'll notice that Emily's breathing in through her nose and then she's breathing out through her mouth. She's also having to concentrate on where the ball is going up and down as well. So you're using a lot of the nervous system integration there. And this is a great one, like I say, to strengthen the diaphragm. And quite often I get the kiddies to put their hands down on their belly so they can feel it coming from down there as well. Kiddies love that one.
Real. So that was a couple of examples of kind of cheek and blowing exercises. Now I'm going to do well, this exercise has got lots of different benefits, but I'm going to call it a dissociation exercise. I'm going to do it first with the retractor and then without. So I've forgotten whose turn it is. I think it's Jill, if you don't mind, Jill. Thank you.
Okay, so this is a really kind of, mainstream traditional myofunctional therapy exercise. Now, it's quite surprising how difficult some people find this exercise because, and say, especially patients who've got TMJ issues, that their tongue and their jaw does not work independently. So this is about strengthening the tongue, but also getting that disassociation between the tongue and the jaw.
I find it really hard to actually
don't do that. I used to demonstrate how not to do that exercise and I ended up getting problems with my TMJ. So I now have a video of somebody doing it because, yeah, you can really cause problems with your joints by that lateral shift. So yeah, it's a really, really good exercise. I tend to, that was a new one on me. I don't usually use the retractors. That's a good idea.
Do it for the just to get the lips out of the way when they find it hard.
That's good.
Yeah. And I noticed, just going on back onto that jaw association thing, it's a big thing for speech, that, because if you're lateralizing the jaw when you're speaking, which is something you do every day, most of the day, then the muscles are so much overworking there, and it's really going to affect your speech clarity. And I think it was on that I managed to get to watch Open Wide, the Muse documentary on Netflix via the VPN last night. And there was they just zoomed in on a kid talking, like jaws just like going like this, and there was absolutely no stability there. So yeah, absolutely, it's a jaw stability exercise. And then I'm going to do the elastic swallow, Jenny. I'm going to do it with one, and then I'm going to do it with 2 or maybe 3.
Yeah, so working on a correct swallowing pattern is one of the main goals of our therapy. So we work with the little elastic that Emily's popped on the end of her tongue. And she's put that up to we call it the magic spot, which is the incisive papilla. And she's anchoring that there. And she's then going into occlusion and doing a big smile to remove the lips and the cheeks from the swallow. So it's just the tongue making that peristaltic wave-like motion into the palate when she's swallowing. And you'll also notice she's like a statue, so there's no movement in the neck. There's none of this kind of goose necking that you often see, or shoulder movement either. So the good thing about swallow is you can retrain the muscles to form an improved swallowing pattern. So even a patient with a really severe tongue thrust, we can get really good results through the therapy that we do.
Yeah, and I'll try and demonstrate a tongue thrust and see what happens to the band. It's hard to do. It moves around or gets swallowed. And then for a lateral thrust, or sometimes just to work on the back as well.
Done it again. Extra bands to help raise the posterior 2/3 of the tongue on the swallow, and just really anchor the back of the tongue.
Well, thank you. Thanks, guys, so much for that. I'm going to go back to screen sharing now, because that's a lot of exercises. Just while I'm doing that, I didn't include any postural ones just tonight, mainly just because a bit more tricky to sort of demonstrate, but we often work with the tongue posture and the oral posture. We work on them alongside body posture, and there's an amazing phenomenon really, and an article by a guy called Fabio Scoppa, and it's called glossopostural integration, and it is to do with the fact that whatever our body's doing, whatever position it's in, or whatever our brain is focusing on, our tongue is up in the palate and our lips are closed, and that helps us to cement that posture. So we do that kind of thing as well. So along the way on this journey of myofunctional therapy, you're doing all of these exercises. We often use a myomunchie alongside that as well, which I can show you afterwards if you'd like. Some myofunctional therapists use myobrace. Some use different equipment like an iCoro or a froggy mouth, and there are different things out there in the market. I think the four of us that are here tonight are usually myomunchie users. So we'd always advise our patients to have body work alongside the myo to help the body adjust to the new patterns that are happening within the head and neck. And it's especially important before or after tongue tie release. We always as well recommend yoga and or sensory integration work for the reasons that I just mentioned with regards to posture and the body's movement, and how we accept that our oral posture is part of our overall posture. Sensory integration for kids can be really great because tongue tie and oral dysfunction does come hand in hand with retained primitive reflexes, but I'm not going to go into that because it would take way too long and I could do another whole presentation all about it. We work on breathing in myofunctional therapy, but we can go a bit deeper with the breathing and actually do some biochemical and some biomechanical breath work. And the kind of breath work that works best with myo is the Buteyko breathing. And the four of us on here all use that as well and often integrate it into the therapy. Even when it doesn't present as an immediate breathing dysfunction, you can almost always find that there'll be benefit from working on that. Then quite often, but not always, there is need for a tongue tie release. So that's controversial, and that's hard for us to deal with, and that's certainly where we need backup from other professionals, and of course it's not something that we can do. So we all use Dr. Zaghi's tongue restriction measurements, and we're constantly reviewing them. So we're looking at lots of different ways that the tongue can be restricted and how its function is affected, but we're continually evaluating that. So we can recommend a patient for release if we see that they get so far into the therapy and they're still not functioning, there is still lots of barriers in place. We can see that the frenulum is still very tight, but we can only do that when we know that that tongue is strong enough to stay up there in that palate during sleep. Because if it is not, and then it's released, it's going to flop. There's much more risk of it flopping back into that airway and worsening sleep issues or causing apnea where there wasn't any before. And the same goes for tongue space. So the actual palate size of the palate and the dental arches, are they wide enough to accommodate that tongue? So we can work on toning that tongue to get it to adapt to that space better. But if that space is just inadequate, then the same thing applies, is that if that tongue is released, we could potentially worsen things. So we need providers that understand that. And we have our own preferred providers who we'll generally refer to. But of course, that's the patient's choice, and we'll work with any dentist or medic, ENT, that will do it. And then part of our job is also to, as Jill briefly mentioned, is to help to prepare the tissues for release, including lip release, that can be, and buccal release. So we're helping to prepare the tissues, and then afterwards we're helping to stretch out, thin out, and repattern again those muscles. So we're helping with scar rehabilitation and helping to thin out and gain elasticity after release. And then lastly, another one where we simply don't have the jurisdiction or the knowledge to do is that sometimes when there isn't that space for that tongue, we just need expansion, or other orthodontic appliances, sleep-based appliances and guards that we can't prescribe. So that's again where you guys come in. So you can see that lots of other professionals potentially are needed to complete the process. So the outcomes that we get are improved breathing. Breathing is the most important function in life. Without breathing, we aren't alive. So breathing, like Caroline said at the beginning, oxygen is what people are most efficient in. So we see improved breathing, sleep, and focus. You know yourselves, if you have a bad night's sleep, you can have a rubbish day, you can struggle to focus. But at least as adults and people who are aware, we can regulate and we can drink coffee. Whereas for kids, this is having a great big impact on their development throughout the day. And we can see symptoms like ADHD occurring and all sorts. We often see better digestion because food is being chewed properly, and improved oral health, which obviously feeds on into the oral microbiome, which Caroline knows such a lot about. We can see improved posture. So often when the head is coming forwards, reaching out for air, or because there just isn't that tone in the tongue, because the tongue lies at the top of that line of fascia in the body, we see improved posture and the shoulders being more relaxed and further back. We see improved muscle function and tone. So we see that speech sounds become clearer. Speaking in general and voices become clearer. Chewing and swallowing gets easier, less effortful. And the one that we don't advertise is the facial aesthetics, but it really does happen. And then finally, we see increased self-awareness, so that they have the ability to take forward what they've learned and notice if there's anything that's gone awry and seek. Well, usually they're enough to be their own therapist by that point, and they've had a lot of education and figured out what's what, but they can always come back to us, and that they become an airway advocate, really like us, and they see the benefits of it and start to tell other people about it. So the dream team who is involved in myofunctional therapy in this process that we know is really powerful. So I've got the myofunctional therapist and the patient right at the center here. And as you know, myofunctional therapists can be from the dental background or the speech and language background. But ourselves here today, even if we are an RDHT or a speech and language therapist, there might be times that we still need to liaise with the patient's own RDHT or the patient's own speech and language therapist. I've got right here at the top, you guys, dentist and orthodontist, and the other medics that we need to refer to. For example, if somebody simply cannot breathe through their nose because of obstruction, we can't do myo with them. We're not going to have any effect. We can't ask them to keep their lips closed and their tongue up and breathe through their nose if their nose is completely occluded. So we're going to always be referring out. Breathworker, and the gang of us here are all doing that anyway. We might need a nutritionist. Body worker, so chiropractor, osteopath, or cranial osteopath. We might need a lactation consultant, movement therapist. There's quite a few different people that we could potentially refer to if we identify that we can't address their issues. And I just really like this quote, that the whole is greater than the sum of its parts, because when we work together as a team, we can cover so much more and achieve so much more. So who, how, when, and where next? That's a lot of questions in one go, but I'm going to make it quick because I think I've run over time. So who would benefit from myofunctional therapy? Well, anybody who ticks those boxes that you can identify has OMDs, especially patients of yours who are wishing to go down that preventative route, or rather than just wishing to rely on a device or that kind of sticky plaster scenario. And always children, always children, because when they're still growing, we can repattern them, we can make big changes, and we can change the trajectory of their facial growth. How can you get in touch with a myofunctional therapist? You can reach out to the BSMFT, that's the British Society of Myofunctional Therapy, where there's a directory, so you can find who's closest to you. Or you could find a practitioner locally. And again, you might think, do you know what? In this case, I think I need a dental myo. We're all doing the same job and we're all going through those exact same motions, but sometimes it's nice to have someone with more of a dental background, particularly if it's, you know, there's perio involvement or TMJ involvement, or you might think, you know, I might need a speech and language myo in this case because there's some sound errors and things. Either way, we're all doing the same job, but just with very slightly different glasses on. When? Well, I would say, again, be led by the patient. Think about their age and their stage, where they're at. Think about whether it's affordable for them. Talk about it with them. And, you know, just use your own judgment. And then where next? Well, I hope you guys have enjoyed this and feel like you know a lot more, and I hope that we can continue to build a network of professionals, all of those professionals there that were mentioned in the previous slide, to start working together. And the goal for me tonight is just to raise that awareness, and that's where we're all at, all of us myos that are so passionate about this field because we see that it works, and we want to raise awareness amongst healthcare professionals, medics, and wider than that, society as well. So I'm going to provide you with some resources and links for you to use. So I'm going to give you, and it is a hyperlink in the PDF that I'm going to send you. It's going to take you to a Google Drive of mine, and I've given you all access. I've opened up the access to anyone with the link that has millions of research files, all categorized, which might be useful for you. Some tools for use in your own clinic. I mentioned before there's a tool called the iCoro, which shares a lot of myofunctional principles and is really great for helping with muscle toning for sleep, people with obstructive sleep apnea. Also works on reflux. So that's a tool that you can potentially prescribe out to patients, and you don't need to have any myofunctional knowledge or qualifications. MyoMunchie is something that we all use. Where's mine? Where's mine? So it's a little rubbery device that we put in the mouth, and we're using to reinforce those 4 goals of the myofunctional therapy that I talked about earlier, and to get lots of movement through the muscles of mastication. I popped on a few ideas for further training if you wish to, and they're most of them are hyperlinked as well when you get your PDF. And then therapists, you know, if you've got questions, just reach out to us. It's another reason why I invited Caroline, Jenny, and Jill along tonight, is just to, you know, so that you can see that we're here and we're just willing to work together and willing to make referrals, accept referrals, and just to keep it all going. So reach out, and you can reach out via the BSMFT or via the British Dental. I don't know how would they find you through dental, guys. I don't know how they would. Or we could be found through the Royal College of Speech and Language Therapists. But there are probably only about 20 of us in the UK at the moment, maybe 30. And thank you for listening.
Thank you.
Okay. Good. So do you have any questions? Or actually, should I perhaps first say to Jill, Jenny, and Caroline, did I miss anything that was really obvious, and anything that you guys you feel like
Amazing. Well done. It was brilliant. It was perfect.
nothing that you really passionately need to add that I've missed out?
No, you nailed it. Well done.
Okay, questions then from dentists.
I have one.
Mhm.
It's more as a mum, I was told that a health visitor came in and said, no, your children don't have tongue ties. And from what I've realised, it isn't an all or nothing. There's an extent thing.
Yes.
And so how do we as dentists, because I think I only recognise really severe ones that have been missed, should a tongue be able to do that? I know what's typical, but when does one refer?
Okay, I'm going to start off, and then probably one of my colleagues will also chip in with more ideas because they're obviously dental. You can look at their range of motion generally. So you can look at how far they can open their jaw, their comfortable jaw opening, then how far they can open their jaw with their tongue to the incisive papilla, and how far they can open their tongue with their tongue all suctioned up. Interlingual palatal suction. And if there's a really marked difference between the jaw and the other two, then there's a big indicator. But what we're doing as part of our assessment is measuring all of those so that we're getting exact, and we're using Dr. Zaghi's range of motion stats for that to actually work out the percentage. We also hold down the floor of the mouth so that we can see how far that patient is compensating by lifting up the floor of the mouth. There is, I would say, if there's a lip tie, and that, you know, that's really visual, the grading of the lip tie, how far the frenulum inserts right into the incisive papilla. The rule is when there is a lip tie, there is always some form of tongue tie. But when there's no lip tie, there can still be tongue tie, but not the other way around. Apparently, yeah. So it's based, but really, those are quite rudimental, really, because it's based on function, and it's based on kind of what you see and what the patient reports. So if they're coming out with any of those symptoms that we mentioned, then you can look at those things. In the drive link that I'm giving you, there are some resources that you can use yourself, some which are visual images that you can compare against, some which are general measurement ones, and then one which is it's called the Fairest 6, which is Dr. Zaghi's what's it called? It's like a checklist for red flags for sleep disordered breathing, and anyone can use that. And that's got pictures of tongue restriction and how palatal width and all sorts. Ladies, do you want to fire in with anything else that they could do as dentists to potentially identify tongue ties?
Yeah, I think I'd probably go off symptoms more than anything. Quite often tongue restriction and posterior caries, not being able to remove food from their back teeth, not being able to get the tongue in that position. I also have a feel around the muscles, especially that digastric. You can feel the digastric really tight. And I often, because coming from like that bodywork side of things, I always ask and palpate kind of the trigger points as well. And then it leads to questions about, oh, do you wake up with a dry mouth? Do you snore? Do your mouth breathe? And then it kind of leads to that. So yeah, I probably go off symptoms. If it's not a tongue tie that jumps out at you straight away, like an anterior. Quite a lot of questions.
So we all know about the insertion point and how much free tongue space there is between the frenulum and the apex of the tongue. And when you see that bowing, that heart-shaped bowing, or you can physically see the anchoring, then it's there, isn't it? But we're talking about these kind of unseen tongue ties. Sure.
Also, patients who need to use their lips to swallow. So when they can't actually, when you put them back, and especially as a hygienist, when there's lots of water, so a lot of patients, when they've got a tongue tie, they will need to use their lips to swallow. They can't actually use their tongue alone. Yeah, they'll hate lying back, or they'll constantly, want to sit up and
compensate
swallow.
in some way, won't they? Like head bobbing or cheek puffing or.
And I say some patients just want to do that anyway, and there's no tongue tying.
Yeah. Well, patients who can't breathe through the nose, they hate coming to see us as well. Yeah.
Any questions?
Well, I've got a question. I have a lot of patients fitted with the CPAP machines, and every third patient you ask, they seem to have one, but none of them have had any myofacial treatments or know anything about it. I mean, is it something that's worth sending them to someone like you? And can you do Zoom consults? Because I'm just looking at your registry. There's not many people down where I am. Yeah, so can you do it on the Zoom, or does it all have to be done in person?
We prefer to do it in person, at least for assessment, but most of our therapy is usually online. We find that works really well. But there's nothing quite like getting your hands on somebody, especially when you're dental. It's all been a bit strange to me in speech and language to get gloved up and put my finger in people's mouths. But there are ways and means that we can do it with photographs and questions about function and certain things on a call. And I think every therapist feels differently about their confidence or their willingness to do that.
Hamish, whereabouts are you?
I'm in Hampshire, South Coast.
Oh, okay.
Well, there's
see if we can put you in
Eva.
touch with. Yeah.
Eva at Myodynamics, very, very good.
Eva at Myo.
Dynamics.
Okay. Okay, good. And I mean, is there an age limit to this? Because I see a lot of elderly patients, and it almost exacerbates it as they get older. You got people like,
Yeah, absolutely.
Yeah.
Oh, there's such a link between, aging and oral dysfunction. And actually, there is so many studies that show that the better oral function you have reduces your chances of certain diseases, including dementia and all sorts. Caroline would be a good person to talk to you about that, but absolutely not. We treat from cradle to grave, as it were. And I know that in my last job, there were patients in their 80s who benefited from myofunctional therapy and who went ahead and had releases even at that age.
You definitely opened my eyes to this. I always wondered what you lot did. Now I know. Yeah.
Yeah, I think it's been brilliant, really eye-opening this evening. Thank you. I know you said that a typical treatment would be 18 to 23 sessions. What sort of time span does that actually cover?
Oh, 9 to 10 months, because
Right.
I said this actually, that's a good point. We usually start off with in the intensive phase. We have 4 phases in the therapy. So we have like an intensive phase where we generally see patients every week for 6 weeks. Then we'll sort of review their progress, and then we generally move down to each 2 or 3 weeks. And then towards the end, when we're really in that kind of that phase that we call synchronization, where we've already habituated the 4 goals, but we're wanting to make them work together, then we generally see the patients just monthly. And the tongue tie release could be anywhere, if needed, could be anywhere from that first review after that intensive phase to the end or after the end. We'd need to then be involved pre and post release for the tissue prep.
It is very much, sorry, it is also, we do work very much with that, as Emily said before, with that person, with their needs. So, you know, sometimes, yeah, it's a long process, and sometimes, you know, it can happen quite quickly. If you change your breathing quite quickly, things can happen, yeah, pretty quickly.
I suppose, yeah, the patient sometimes, I guess, has to be ready for that. There might be a bit of resistance, I imagine, for especially the breath change. And if this was going to be sideways to, say, TMD therapy or splint therapy, or even orthodontics, where does it sit? I'm thinking of course, the patient I saw today, you know, large overjet, incompetent lips, lip trap. So how does a patient like that, he's 10, if it's not possible, or is it possible to train a lip seal for such a great overjet, or would there need to be a pause in the treatment to have some orthodontic therapy and then pick the treatment up again? Or how does that work in the more extreme ends of the bell curve, if you like?
Oh, what a good question. I'm going to ask Jill, Jenny, or Caroline to answer it, being dental.
So what I would say is that you want to look at changing function as soon as you can when you're working with an orthodontist. It doesn't mean to say things are going to be perfect straight away until you start changing the orthodontic occlusion. But it's really good to start, because there are going to be lots of other issues going on. We can still work with swallow, because obviously that's going to be so important. We can still work on tongue position. We can still get, even if you can't get great lip seal, you can still work on a really good tongue position to start improving nasal breathing. If you're getting the nasal breathing better as soon as the orthodontic work is kind of progressing, so that you can get good lip seal, then you can start doing lip seal, and you've already got the retraining of the breath work going. Sometimes we do it on a bit of stages, because I'll go, actually, we can get this far, and then we'll kind of do a little maintenance stage, and then I'll see you again when going into another phase of the orthodontic work as well. But it's always a good start to try and get function as really kind of the foundations of good function, because then you know that you're not going to get the relapse with the orthodontic work. And I say, if you can get that going, it does change really, really quickly, and it can really help what you're doing.
Yeah, and I think that quite often there might be underlying habits as well, because we haven't talked about thumb sucking as well. So, you know, you've got to get rid of those habits, and any kind of movement is good. So doing it before, middle, after, it's exercises. So, you know, obviously tongue tie, you know, there's an incision, but with the myo, it's just exercises. So, you know, it's not going to cause any harm. I'm working with a dentist in Leeds, and he's got an ALF in these 2 kiddies that I'm working with, and we're just learning as we're going. So all the kids are different. So we had a Zoom, and Emily joined on the other day, and we chatted with the osteopath, and she said, I've been working with these kids since they were born, and since you guys have been doing whatever you're doing, I've seen the biggest amount of cranial growth. So for us, we're like, oh, what is it? The alpha? Is it the myo? Is it the getting them off the thumb? So, but it's everything. And this is why when Emily said we're working on the body as a whole, it is about that integrated approach. because you can work on the fascia, because all the, you know, the tongue tie is fascia, but just working up here, you know, the body is one big system. So I think it's about just working together for the best outcome. But the main thing is, can that person breathe, with the breathing at the forefront.
Yeah. And tell me, what did you say there? You're working with the ALF? What did I miss that? What is that?
It's just a really light wire expansion device.
Okay.
It's
stand for alternating light forces or assisted light forces.
Yeah, something like that. And basically it's an expansion appliance, but it's very, very gentle. So it works with the integration of the craniosacral system. So the premise is to really lightly move the cranial bones in conjunction with changing those patterns. And then if you work with an osteopath, then if there's any challenges or anything stopping it moving, then they can gently release the tissues as well. So yeah,
another great thing. Sorry, Caroline. Another great thing about the ALF is that the child or adult, indeed, has access to the palate, because I got my own kid as a knee-jerk reaction when I first realised about airway ALF, and I got my own kid into expansion. And it was a great big thick plastic palette, which actually she'd no access to the palette, so we couldn't do any myo. We could work on a few functional things, but on the whole we couldn't, because she couldn't feel it. She didn't have any proprioception there whatsoever. And I actually think it caused lateral tongue thrust, because there was just so very little space in there that the tongue had to go somewhere and it was coming out the sides. I think that could be an extreme case. I wouldn't say that would always happen, but we can work alongside ALF much better than we can any other appliance that covers the palate, because that's really where we need that proprioception.
And I have then a question on from that. So, and maybe dentists can help answer this. So sometimes if I'm doing an appliance, I would choose between doing an upper appliance or a lower appliance for a patient. And essentially they do the same thing, but the shape of the teeth or the missing teeth or something might direct you more to the upper or the lower. The upper one wouldn't cover the full palate, but I think it would cover the incisal papilla. So does that change how useful that is? Would that be directing you more to a lower one?
I think it would be better.
Don't know. Yeah, a lower one. Don't know. I think.
What's the appliance for? Sorry.
So it would be to sort of neutralize any discrepancies in the bite. So to make the bite as ideal as possible. So their joints could be seated and their teeth bite nice and evenly down both sides. And then they've just got nice sort of shallow ramp that they can easily move their mandible or their lower teeth around. Because sometimes the way their teeth come together just prevents that freedom of movement or makes a more awkward position for them to bite into. And again, I'm thinking of a patient. She was the one the report came in from, and she's very deep overbite. She's very constricted, I think, at the front as well. And even when you're talking to her, I can see she can't breathe. You know, she sort of gasps when she's talking to me and very, very anxious. And I think it's because her body thinks it's constantly dying, you know, because she's just not breathing properly. So with her, if we were going to do some appliance or even ortho work, I'm thinking, where does that sit in? Because you're saying the breath is the foundation. Let's get that right first. But if she's going to be doing training exercises with the tongue and then she was wearing an appliance, maybe it's not even the same patient. But would that direct you more to an upper or lower appliance? But I guess
I don't know, because you can still move your tongue. I don't know how long she would be in the appliance for or not. She's still got not kind of covering the whole of the palate, is it?
No.
ideally getting the tip of the tongue on the incisive papilla is ideal, but I suppose she's still going to get.
And it's only going to, it would only be maybe, I don't know, 2 or 3 millimeters thickness at that area. So if that's a wee bit lower, that's not a big deal, I assume.
Yeah, I suppose that's, I don't know. I don't know. Jill might be.
Okay.
I think you'd have to maybe do what Jill said and sort of suck it and see, take the breathing first, and then maybe do the pauses if it wasn't working. She could get that feeling right. What do you think?
Yeah, I think that's it. I think it's like you say, just to go along, let it unravel, and then just keep reviewing it and seeing how it's going. I think she's in such a state just now that anything forwards is going to be a benefit for her. You know, it's not great where she is now. So
and the fact that she's found myofunctional therapy, like she's been searching. So
and she's found it on her own, to be fair. And she said to me, can I leave? I'm glad I've met you, but can I leave my next visit till I see the myofunctional therapist? And then the report is literally the weekend just been forwarded to me. So I was very curious about today, and I need to maybe go and read that again and just digest it, and then
reach out to
how
them.
I might fit.
Reach out to them and just say you're really interested. Teach me, because that's like a myofunctional therapist dream for a dentist to reach out and say, wow. So they'll work with you. They'll teach you. So that's what I would advise. Reach out to them.
Right. Thank you. Yeah.
Okay.
Does anybody else have any questions?
I could be here all night, but
I know. I'm going to have to shut up.
It's probably way past your bedtime now in Nantes.
It's 1:30 in the morning. Yeah.
Oh, God.
Oh, you do so well, Hamish. Oh.
Yeah.
Thank you, Emily. I really, it's obvious you and your colleagues really know what they're talking about, and that we could all learn from doing everything a lot more together.
Thank you. And
thanks very much.
Yeah.
Thank you.
Guys.
Right, thank you very much. That was excellent.
Been really good. Yeah, thank you very much. Thank you.
I'll pop the PDF over to Jo, and then she can share it with you all, and that'll have these links on.
That's super. Thank you.
So much.
Bye-bye. Bye.
Thank you, everyone. Thank you. Bye-bye. Bye-bye.